All right, hello, I'm Dr. Bethany Samuelson Bannow, Deputy Editor of ASH Clinical News, and we are here live on site at ASH 2025 in sunny Orlando, here bringing you some of the most exciting science that we're seeing. And I have the pleasure of being joined by Dr. Gloria Gerber, an assistant professor at Johns Hopkins University, to talk about abstract number 1114, which is a really exciting real-world study of switching between different complement inhibitors for PNH. So, Dr. Gerber, can you give us a brief overview of what the different classes of inhibitors are to help us think through why folks might be switching?
So I would put things in kind of two bins if we're going to think about this. There's the terminal pathway inhibitors, which are the ones that were first approved. The first complement inhibitor approved was eculizumab in 2007, right? And that's a C5, a complement C5 inhibitor, so it blocks that terminal pathway, the formation of the membrane attack complex, right? And intravascular hemolysis. And then, as we continue to treat patients with these terminal pathway inhibitors, we realized that while it improved hemoglobins, quality of life, and blocked intravascular hemolysis, and most importantly, really attenuated thrombotic risk, right, which is a source of mortality. And now mortality in PNH patients is pretty comparable to age-matched controls, right, because we've reduced that thrombotic risk so significantly. But we did note that there's a proportion of patients that have ongoing symptomatic anemia and transfusion dependence. So maybe about 25% of patients who are having ongoing transfusion requirements on terminal pathway C5 inhibitors. And that's a mechanistic consequence of extravascular hemolysis. Now I'm going to note there's many reasons for ongoing anemia in PNH, and it's incredibly important to rule those out, right? So if you have concomitant bone marrow failure, and that's what's driving the anemia, no matter what complement inhibitor you're on, you're not going to improve your transfusion requirements, right? Or not very significantly, right? So then we realized there was this group of patients who had ongoing symptomatic anemia and transfusion requirements on terminal pathway inhibitors due to extravascular hemolysis. Because now that you're blocking intravascular hemolysis, those PNH red cells are surviving longer, but you still have proximal complement that's active. So these cells are getting tagged with C3 and destroyed, in the liver, in the spleen through extravascular hemolysis. So then came about the proximal or alternative pathway inhibitors. And so we have several that are FDA or EMA approved. There is pegcetacoplan, which is a C5 inhibitor. We have iptacopan, which is a C3 inhibitor. Oral pegcetacoplan is usually about twice weekly subcutaneous. There's an on-body. So it's a subcutaneous on-body infusion. And then there's also danicopan, which is a oral factor D inhibitor, but that has to be combined with a C5 inhibitor. So that's as dual therapy. Okay. And so what this abstract looks at, and I think the real world data, especially in PNH, is so important because we know compliance can be different in trials, exposures can be different in trials. So that's what I really like about this abstract. And I think this is an incredibly clinically relevant and pertinent abstract right now in PNH because patients are switching and we don't have great data about how to switch, outcomes, right? There was no head-to-head comparison of these agents, like the proximal inhibitors. Right. And the comparison between the C5 inhibitors and kind of the alternative pathway inhibitors in the clinical trials was done in that group of patients who had that ongoing symptomatic anemia. So I think this real-world data is so important. And so what they're looking at is proximal to proximal switches and then proximal back to terminal switches. And there's different reasons for that, right? Some were for hemolysis, some were for side effects like GI intolerance. About 30%, and this might be less relevant, were switched because they were on a trial before, the trial ended, the agent wasn't approved, and therefore they had to switch, right? Yeah. And then, of course, you want to remember things like pregnancy, So we don't really have, we have virtually no data with the alternative pathway inhibitors. And of course, patient preference, right?
Right.
Which is important
Right.
as well.
Yeah. In your practice, what are the most common reasons you see for patients switching between therapies?
Yeah, I think that's a great question. So of course, there's that classic trial indication where a patient has ongoing symptomatic anemia on a terminal pathway inhibitor that we're, making a switch. And that's probably the most common. But a lot is becoming patient preference, right? I think PNH patients on the whole are it's a rare disease, but patients are incredibly educated. And there is so many patient organizations, informal conversation forums. So patients are kind of talking about their experiences with these agents. And so some of it is patient preference, lifestyle. Maybe an oral inhibitor meets their lifestyle much better. Maybe they, so I think there's a bunch of different reasons, of course.
Yeah.
But I think the, important takeaway points is that, certainly with proximal to proximal inhibitors or proximal to terminal, you don't want to have gaps, right?
Right.
So there, unfortunately, in this study, in some of the proximal to terminal pathway, especially the patients who were coming off trial, there were gaps in therapy, and those patients had pretty severe hemolysis. And by that, I mean need for transfusions, a 3-gram hemoglobin drop. But there were also some patients who were switching from proximal to terminal for various reasons without any kind of treatment interruption. And you don't really need a significant long-term overlap or a down taper per se is kind of what this abstract is suggesting, but you don't want a gap, right?
Right.
But even some of those patients who are going from proximal to terminal did have hemolysis, and you probably could see this as, you have this large PNH red cell clone because PNH cells are surviving longer, the red cells are surviving longer when you don't have intra and extravascular hemolysis. And then again, it's probably through a mechanism of that reintroduction of the C3 loading of the red cells. And so we did see some hemolysis in those patients, but also in some of the proximal to proximal switches.
Yeah. In your practice, what do you typically do? Do you do overlap or direct switch or?
So usually more of a direct switch.
Yeah.
So certainly with pegcetacoplan in the trials, patients were, because it's subcutaneous, were overlapped with both the C5 inhibitor and pegcetacoplan. So I would, of course, still do that for the first month, I believe.
Makes total sense. Thank you so much for sharing your insights and expertise. We really appreciate it.
Of course.
And thank you for joining us again here with our live coverage at ASH 2025 in Orlando. As always, you can find more information on our website or coming out in our January edition with lots of meeting coverage there. Thank you for joining us.